Beverly Hills Dental Corp. Personal injury. Subject: oral facial trauma. Clinical case number 1. Tom Kalili, DMD, QME, 20 years lecturer, advanced prosthodontics, biomaterials and hospital dentistry, UCLA. 62 research publications, international and American dental research, US and global patents, editor Journal of Orthodontics, Brazilian Jiu-Jitsu black belt and world champion 2010, Boston University Entrepreneur Award 2010. Clinical examination of patient. This patient was involved in a trauma referred by an attorney for main complaints of TMJ pain, dental displacement, dental fractures, and mouth pain. So patient came in and we did an initial examination. In addition to TMJ and mouth injuries, she had a severe laceration of her tongue. So we did a comprehensive examination. Usually with TMJ cases, you would like to document everything as thorough as possible with the expectation that there is going to be a deposition and they pay you a fee for your deposition. When I started 25 years ago, my fee was $250 an hour. And now my fee is $1,500 an hour with minimum 2 hours. So this is a good way to have an adjunct to your revenue. It's very exciting, but you need to be able to stand strong, to be convincing, to be aware of the latest research publications in your field, and to be able to back up what you have examined. Therefore, a thorough, comprehensive medical report is critical. These reports are in the SOAP narrative format. SOAP, S for subjective, O for objective, A for assessment, and P for prognosis. And you break down the report into those categories. This patient, I have developed a table where on the left you'll see the main complaints: TMJ pain, teeth pain, and teeth displacement. And that would be under the subjective analysis. Then objective analysis, you would have right TMJ clicking, electric pulp testing for positive to specific teeth, and altered lifestyle. And then you have radiographic assessments, and then you would document what are the radiographic findings, and then the treatment plan, and what type of limitations, which is probably the most important for the attorney. Chief complaints. Patient came in with chief complaints of pain to her jaw upon opening, difficulty chewing, jaw joint locking, clicking, headaches, dental fractures as patient points to the upper and lower anterior teeth. This is a clinical photograph of the patient. History of the patient is remarkable for an automobile accident. As patient states that she was driving her car, an automobile cut across, attempted to make a left turn, and struck the patient. As a result, the patient suffered severe injuries to her mouth, jaw, and intraoral soft tissue. TMJ findings were remarkable for deviation of the mandible. So you need to make sure that you're measuring the right and left excursive movements, protrusive and retrusive mandibular movements, and interincisal mouth openings. You need to measure at what point is the clicking occurring. Normally between 30 to 35 millimeters when the mouth is opening, which is about 2 knuckles, the jaw is going into rotational movement. After the 30-35 millimeter mouth opening, the jaw goes into a translational movement. And if the TMJ is severely injured and if there's disc displacement, normally it would be difficult for the jaw to translate beyond the 30-35 millimeters. So if the mouth opening is limited to 30 or 35 millimeters of mouth opening for a male, that means there is definitely translational issues, which becomes primarily due to a disc displacement. Intraoral examination is remarkable for multiple dental fractures and teeth displacement. Intraoral exam continued. It just discusses the different treatments that we're going to implement, assessment of the tongue, and documentation of the type of complaints and permanent or temporary to permanent losses patient could have as a result of her injuries. Head and neck exam is remarkable for right TMJ clicking, swelling overlying the right TMJ. The clicking is at 30 millimeters of mouth opening, which is indicative of a rotational movement and absent of any translation. So again, this would be consistent with a disc displacement, further verified by radiographic examinations. So these are the type of discussions that you would have in a deposition and ultimately in preparation for trial. Indirect impact can in fact cause TMJ dysfunction. If you have a hard snap to the back of the head, even without direct impact to the jaw or the mandible or the temple region, this can cause TMJ dysfunction. So you don't need to have direct impact. Regions of pain is discussed here, the areas of pain that the patient has. This is a nice schematic drawing that I did to demonstrate the disc displacement, which in this situation is anterior displacement. And when you're going anterior displacement, that forces the head of the condyle to be retruded in a posterior direction. That's the more common types of dynamics that take place. Now, when a disc is anteriorly displaced, that's indicative of the ligaments and tendons, the superficial lateral pterygoid ligaments and tendons predominantly regulate the disc movement. And when they are torn, because of their 90% avascular nature, that is considered as a permanent injury. So this is something that is critical for the attorney to understand and convey that message to the jury or the attorney on the opposing side. So regardless of how much you're able to increase the mouth movement, increase the range, diminish the pain, this type of injury, again, because of minimal reparative mechanisms for blood supply and nutritional supply, this is a permanent injury. This slide discusses the temporomandibular joint. It's analogous to other 200 joints in the body. So it's not some mysterious joint that people are trying to shove to the side. It's a real joint. The critical thing about the TMJ is that it is much smaller than most other joints in our body, and also the disc is biconcave. And finally, the reason that this is a very vulnerable joint is that under normal use, the mandible is shifted downward and forward, hanging like a grandfather clock. So it's like a sling going back and forth. Rarely are we walking around clenched in centric relation. We did a research study with the UCLA football team, and that again demonstrated using thermographic analysis and so forth that the mandible is rarely closed. It is usually hanging downward and forward. So in that situation, a sudden impact, a jolt, can cause a whiplash not only to the cervical spine but to the TMJ. This is some discussions by Dr. William Solberg, who was one of my professors and director of UCLA TMJ and Facial Pain Clinic. And I was involved with coming up with forms and assessing patients and so forth. And after that, I began to do some research studies with Dr. Bart Gratt, who was the chairman at the time of UCLA Radiology. And so I got a lot of experience, and it was an honor to work under such pioneers in TMJ and facial pain management. So the medical history of this patient is critical because the opposing side is going to want to shunt all the patient's complaints to prior to this accident. So if there's any evidence of arthritis, any evidence of prior accidents, any other systemic conditions, any developmental conditions, those are all going to be contributory to diminish the gravity of the injury that patient sustained to be directly related to this accident. So it's critical to get a nice medical history and also a dental history. You always want to make sure that you request for prior records. You want to make sure you want to have a conversation with the prior dentist or at the minimum dental office manager to see if the patient had any prior TMJ treatments, any prior orthodontic treatments, which would be critical to this case, or any other mouth injuries, dental fractures. And that way you're fully covered and you're not embarrassed during a deposition when they ask, doctor, did you look at the medical history? Did you look at the dental history? Did you look at prior dental records? Was there any evidence of any of these findings prior to this accident? So you want to be prepared for this. By the way, I'm just pretty much sharing this with you off the top of my head. I have seen over 2,000 med legal cases, so I have done this more than 5 or 6 times. Haha. Neurological function. There is loss of sensation. You want to make sure that you do a sensory analysis for sensation and also loss of motor movements to any of the head and neck anatomical structures. You want to make sure that you look at all the cranial nerves. You want to go through the cranial nerves that you studied in school. You're actually utilizing them now. Document them in the report because the patient had a tongue laceration. You want to make sure you make an assessment. You want to do a taste analysis. This is a nice little schematic representation of different anatomical portions of the tongue and what kind of tongue map they have, where they cover where is the bitter sensors at, the sour, the sweet, the salty. And then you want to have jaw mobility assessment. This slide is nice because it shows the normal, the clicking, and the locking of what causes each stage. Predominantly, it's related to the head of the condyle and fossa relationship and how the disc can float back and forth with the mandible under normal conditions and how it anteriorly displaces the disc, posteriorly displaces head of condyle, causing clicking and sometimes locking. So that's what this just discussed, the above representation. And then you want to look at the pain-free interincisal mouth opening. So you want to make sure that you document this thoroughly. You also want to convey to the patient that if they go to an independent medical examiner hired by the insurance company or the opposing doctor, that the doctor can only do passive assessments, no radiation, no manipulation of the jaw above and beyond the level that the patient can withstand. The doctor is not there to treat you. Thereby, the doctor has it will be violating the medical or dental code, that since they are not your treating doctor, they have no authority to perform anything that's invasive. So you need to make sure, even impressions, you want to make sure your own doctor performs the impressions for you. Even x-rays, you want to make sure your own doctor performs the x-rays. You don't want to give any ammunition for the independent medical examiner to diminish the severity of your injuries in relation to this accident. Craniomandibular palpation, you want to make sure you perform a thorough palpation. If there's overlying swelling overlying the right TMJ, like in this case, you want to make sure you document it. You want to make sure you take pictures and identify these pictures into your report. These are nice graphs. I did this on Excel, where you document the visual analog scale, VAS, and the patient would identify at each visit the type of pain the patient would be having for regards to the headaches, and then we would have different slides for TMJ and for mouth injuries. And then right and left pain scale graph. So this discusses the previous table. Intraoral examination. You want to look at soft tissue. You want to look at the dental fractures. You want to look at dental displacement. You want to make sure the alveolar bone housing is intact. There was no fractures of the alveolar bone. And you can do that when you're manipulating the teeth. Is it only the teeth that's moving, or is it several teeth moving together in harmony? And is there any soft tissue displacement? That would indicate that there may be an alveolar crestal fracture. This is a nice graph that demonstrates the range of mandibular movement with regards to protrusion, retrusion, right and left lateral excursive movements, and interincisal mouth opening. And you can do that graph, and then each visit you follow up, and then you do a progress of how the curve looks with regards to improvement, if any, of the different range of mandibular movements. This is a tomogram, which on the left is it shows the right TMJ, the condyle-fossa relationship. Those are the key things that you want to look at. And on the right side, you're facing the patient. So when on the right side of the x-ray is the left side of the patient. And you can see in this tomogram that the left TMJ, left condylar head, is more anteriorly displaced as compared to the right side is more retruded. So that would indicate that the disc has popped forward, causing pressure for the head of the condyle to be retruded position. So these are the radiographic findings. You want to go ahead and document those for each step of the way. And then the preliminary diagnosis, right TMJ disc displacement, indicative of tearing of the attachment apparatus, dental fractures to the upper and lower anterior teeth. Overall findings consistent with traumatic jaw and teeth injuries. Treatment plan. You want to perform some orthotic prosthesis, TMJ physical therapy, TMJ trigger point injections, where extraorally you inject some carbocaine into the joints, and then you assess the movement to see if the range increases. And if it does, then it would be more of an indication that there's no fractures in that region. It's not a hard endpoint. Vapor coolant, spray stretch therapy, ultrasound therapy, basic conservative TMJ modalities. And then home exercises, you go over exercises that I've documented in this slide, which talks about the right and left excursive movements, open and close movements. When you're opening your mouth, you bring the tip of your tongue down to the floor of the mouth. When you're closing, you bring your tip of your tongue to the back portion of the palate, and that forces the jaw to get in the most retruded position. And then the treatments. So we began to perform interdental fixation to stabilize the teeth by placing composites at the interproximal points. You can also place a wire across to stabilize the area to minimize added trauma to the partially traumatized teeth. This is a schematic representation, a drawing that I did to demonstrate where the teeth are, the nutritional supply coming to the teeth, and which cranial nerves, the foramina coming out of in the skull. Remember back in the days in anatomy? And then tooth displacement. So is it partial or full avulsion? If it's full avulsion, that means the teeth have been knocked out. Partial avulsion is that the teeth have been displaced. That's verified by thickening of the periodontal ligament. If there's increased thickening of the periodontal ligament as compared to the untraumatized or non-traumatized teeth, then that would be indicative that these teeth have been partially avulsed. So then you do a follow-up exam, you go through all these things, you discuss with the patient that due to the severity, she may have functional deficits, aesthetic issues, speech difficulties. So these are critical things that the attorney on the opposing side needs to know, and ultimately the jury, so they can get a visualization of the deficits that this patient is undergoing. This excess forces from the patient's impact resulted in anterior disc displacement of the right condyle, causing head of the condyle to displace posteriorly. So this is referred as a retruded condyle, radiographically evident with this patient. The condyle fossa would no longer meet harmoniously. The result is TMJ clicking, snapping, popping, locking. And these are the findings that you need to discuss with the patient. And this is a orthotic device that was fabricated for the patient. What it does is decrease the stresses to the right and left and the upper and lower anterior teeth by distributing more evenly, harmonious balance with each force, masticatory forces, so it's no longer pointing to any one specific localized regions. The more uniform the force of distribution, then the less localized stress, which would increase the propensity for healing. So you tell the patient, the attorney, that you're always available to be contacted as long as there is an authorization signed by the patient. And I want to thank you so much, and I hope you were able to achieve some information from this lecture. Good luck with everything.